So I'm going to start off tonight with my talk, which is the early diagnosis and recognition of cerebral palsy. I just want to mention before we start that we are going to have 8-minute talks and 2-minute Q&A followed, and at the end of all of our talks, we'll have another period of time for questions and answers. And at any time, of course, you can interject a text in the text messaging center. So my disclosures, none of which are pertinent to tonight's talk. Cerebral palsy is not a disease, it's a syndrome. It's a heterogeneous group of non-progressive clinical syndromes characterized by motor and postural dysfunction. There's a huge range in severity, all due to abnormalities in the developing brain. 50 to 75% of kids with CP acquire their lesions between 24 weeks and term age. It's the leading cause of childhood onset disability in the US, and the incidence of CP is reported to be hovering at 2 to 4 per thousand births, fairly stable, and it's stable pretty much across the world, with the exception of some areas in Europe where there may be a decreased. The prevalence is due to increased survival rates of preterm infants and increased survival of individuals into adulthood. So despite improvements in perinatal care, we're still seeing the same number of infants that are. The causes are myriad, and run from infection to stroke to metabolic disturbances and disorders. This would point out that genetic susceptibility has also been shown to be quite real. Recent studies point out that 30 to 40% of kids diagnosed with CP have genetic abnormalities. Cerebral palsy is not static. The appearance of neuropathologic lesions and their clinical expression can change over time as the brain matures. But the primary condition, the insult in utero, is not progressive in the neurologic sense, but the secondary conditions that develop as a consequence of that primary insult, i.e. hip dysplasia, deformities, or contractures, do progress. They may be preventable with early diagnosis and treatment. Currently, in this country, most children with CP are formally identified at about age 2. This means that often there's a vital window of opportunity for therapy and other interventions that is lost. So early detection is an emphasis of this center and many others. Why does early detection matter? Studies have suggested that cortical spinal tracts exist by the prenatal period. Therapeutic interventions can drive these circuits during critical stages of plasticity. Neuroplasticity is dependent on early experiences to stimulate the organization of neural interconnections. And environmental experience drives CNS development. The time between when suspicions arise and the identification is made can be very stressful for the parents, and we should try to minimize that. There are lots of impediments to early diagnosis. On our part, the medical professionals want to delay that bad news. There's a tendency to want to wait and hope the child grows out of it. Or maybe we just didn't notice it. There's a wide variety of causes, and that broad differential, along with a lack of knowledge about the importance of early interventions, all interfere with the early diagnosis. Patients with cerebral palsy achieve about 90% of their motor function by age 5. This makes early intervention really, really important. If we want to, CP is considered a childhood disability, but the condition persists into adult life. we can see from this graph that the red marks the 20-year-old and beyond in this demographic. Further highlights the importance of early intervention, as the benefits that we achieve can last for a lifetime. What's the evidence behind early intervention? This was a meta-analysis in the Cochrane Library that concluded that intervention improved cognitive outcomes at infancy, motor outcomes, and cognitive outcomes. It was inconclusive about evidence for effects persisting in school age. There's early intervention improved motor outcomes in infancy, and that favored intervention in the early age group. Early intervention improved cognitive outcomes at infancy as well, again, favoring intervention. What are the diagnostic methods for this early diagnosis? We have neurological assessments, neuromotor assessments, and neuroimaging. The neurologic assessments in recent years have keyed in on the Hammersmith, which seems to be one of the most commonly used across the country in the neonatal follow-up. Neuroimaging is becoming more and more important. Neurologic conditions in infants admitted to the NICU is often evaluated by cranial ultrasound, but more and more also with MRI. Magnetic resonance imaging is the preferred imaging technique in near-term infants with hypoxic neonatal encephalopathy, and it's also increasingly used in preterm infants. The best age right now, however, for MRI is term. The neuromotor assessments include general movements assessments, and I'm going to spend a couple of minutes talking about that one. GMA is the best diagnostic predictor based on meta-analysis. These studies have shown that general movements have a sensitivity of 98% and specificity of 91% when included with the other assessments. General movements assessment has a historical context in that it's been around for a long, long time, and in fact, since the 1940s, but didn't really grab hold of the worldwide CP community. Prior to the 1940s, there was little organized care, but the diagnosis and rehabilitation was certainly picked up in the 1930s and 40s. And the best, well-established, best diagnostic method that they observed was observation of motor behavior. This was particularly true in the European community. General movements are spontaneous movements that are indicative of nervous system function, and these were classified as gross motor movements with variable speed and amplitude, lacking distinctive sequencing. GMs occur from 7 weeks to 3 to 4 months post-term, and the assessment of those movements is the most predictive clinical test of neuromotor function that's available for use between birth and 20 weeks post-term. The assessment's purely observational, and it's fairly easily administered in a clinical setting by a trained person. So these are the 3 types: preterm GMs, writhing GMs, and fidgety GMs, all of which have a different purpose and timing. The preterms are from 28 weeks until 36 to 38 weeks, are extremely variable movements and include many pelvic tilts and trunk movements. The writhing movements are from 36 to 38 weeks until 46 to 52 weeks. And they're forceful or writhing motions that are added to the variable movements. In comparison to preterm GMs, writhing GMs are slower, and there's less participation of the pelvis and trunk. Fidgety GMs are the most frequently used to evaluate CP, and they appear by 4 months post-term, beginning in the majority of children at about 1.5 months post-term. Gradually, they're replaced with goal-directed movements, which can impede the diagnosis, making that early diagnosis assessment really critical. A continuous flow of small, elegant movements occurring irregularly over the body. Head, trunk, limbs participate to a similar extent, and small movements can be superimposed by large and fast movements. GM are classified by the quality of their variation in complexity, and only 10 to 20% of 3-month-olds exhibit totally normal optimal GMs. Majority of infants are classified as normal suboptimal. GMs and definitely abnormal children are cramped. So here's an example of normal general movements on your left, and on your right are cramped and synchronized movements. On your left are normal fidgety movements, and on your right, abnormal fidgety movements. So this has been applied widely in Australia, and the sensitivity and specificity has been shown to be quite exceptional. The sensitivity in this study of 259 high-risk infants was 98%, specificity 94%. So you can see why we're pointing this particular technique out as a way of making that early diagnosis. So thanks, everybody.